All right, so we're going to begin our discussion on drugs for the immune and nervous system. So, starting with our immune system, uh, this is kind of a functional system as opposed to a anatomically based system because this system operates everywhere in the body. It operates in organs, it operates outside of organs. It's literally all over the place, and it tends to be concentrated in key areas where bodily tissues are going to be more susceptible to infection and injury. Again, something you may not have taken away from anatomy and physiology is that the immune system is not just for infections. Inflammation is actually an immune process, and inflammation is a key part of the body's ability to heal. So, our main tissues are our white blood cells, which can be divided into our leukocytes and our lymphocytes. Lymphocytes come from lymphoid tissues. Those are our B cells, T cells, NK cells, etc. And our white blood cells are things like your neutrophils, your macrophages, okay? Your lymphocytes are technically classified as white blood cells as well, but lymphocytes are very different from the other white blood cells, and we'll talk a little bit why. But it comes down to the idea that lymphocytes provide our true immunity, especially in the long term. The other ones, like neutrophils, are really just first responders that are designed to slow the spread of infection while our lymphocytes actually begin their job. So acquired immunity. Acquired immunity is basically how our body learns to protect itself. We'll talk a little bit about that in the long run, but when you are born, you don't actually have really any immunity at all. Your body doesn't produce all of the cells or antibodies necessary to go through your daily life. And that's a major problem. You can get a little bit of antibodies through the placenta as a fetus, and you get some through milk if the child is breastfed. But other than that, you're lacking a large amount of the necessary antibodies of all different types. So, what are antibodies? Antibodies are a substance made by B cells, okay, specifically the plasma B cell. And these antibodies, they bind to an antigen. Antigens are basically a target for the antibody. Think of a lock and key style of interaction here. Every antibody is only specific to one antigen, okay? So if you have a plasma cell, that single plasma cell only makes that one antibody of that one type for that one specific antigen, okay? Also, as a organism, we have our own universal antigen. This antigen is how our white blood cells can actually recognize that we are not foreign, that it should not attack us, and it's sort of like having a hall pass, right? This is one of the reasons why cancer is actually so hard to stop. Our immune system cannot actually respond properly to cancer, despite the fact that cancer cells are not normal cells. They are harmful to us. Our body does not recognize it that way because they have the hall pass, right? Now, the one caveat to that is a subtype of lymphocyte called natural killer cells, and they can operate under a little bit of a different process where they actually can attack dead and dying self cells. That's very important, not just for the body, preventing cancer, but it is also very important for helping the body essentially speed up the recycling of our own cells through the naturally planned processes like apoptosis, and macrophages can also help with that as well. So our diagram here kind of shows you the idea of a barcode as opposed to a lock and key. Barcode is also another good idea. So antibody production. These white blood cells, the B cells, they come across this antigen and they'll start making antibodies for it, right? So that's the basis of this. They convert, they become that plasma cell. And here it tells us that the antibody is a Y-shaped protein. Well, that's not actually true for all antibodies. Remember, there are 5 classes of antibodies. Not all of them are Y-shaped, but our body's first initial response is that Y-shaped IgM and IgG. That's typically the primary 2 antibodies you see related to things like infection or response to non-self cells. You'll see something like IgE, which will be useful in hypersensitivity reactions. It's not always as simple as this Y shape, but keep the idea of Y shaped in mind, as the Y shape essentially allows it to have 3 different binding sites. It can actually bind 2 antigens, and then the other end can actually attract cells like neutrophils, can also attract T cells, and it can attract macrophages, which is all very important because that antibody almost acts like a magnet for all of those things. And so then you get cells that are designed to actually attack and destroy the targeted antigen being attracted by the antibody bound to the antigen, right? It gives those cells a specific target to go after. With the general antibody-mediated immunity, once you are exposed to an antigen, you're going to have B cells in your body, typically hanging out in your spleen or in your lymph nodes, and those B cells will just hang out there and wait to be activated by that antigen again once your body's actually defeated the pathogen or whatever the antigen was, right? Because not all immune responses are appropriate, and not all immune responses are actually against something that we should be destroying, as we'll talk about on the pathophysiology side of the course with autoimmune diseases. You'll often sometimes hear this called humoral immunity as well. So naturally acquired immunity, this is one of the divisions of how we describe immunity. And basically, for it to be naturally acquired, you naturally come across this foreign antigen that stimulates the immune response. So this would be like, you're out at the mall, somebody next to you in line is coughing. The pathogen, goes through aerosol droplets, you inhale it, you now have pathogens in your body. Your body's now fighting against it. We also have naturally acquired immunity through transmission for the fetus, like we already mentioned, through the placenta and the breast milk. This type of immunity for infants is basically the only way that an infant in its first few months is protected. If you remember back from anatomy and physiology, basically bone marrow is where your B cells are made, and the thymus gland is where T cells are made. But the process of making these cells is not that straightforward. It's highly energy intensive, and it actually takes a fair bit of time. In fact, we talk about it can take 7 to 14 days in a normal adult to actually develop new lymphocytes, right? So that's why you might notice, a week ago that your lymph nodes in your neck have started to get a little bit enlarged. And then a week, and a week has passed, and now you start to have a cough, right? Your body actually has been fighting that pathogen for a week. and it essentially has to mobilize the army, so to speak, when it comes to your lymphocytes. Because again, while neutrophils and macrophages are incredibly powerful white blood cells, they're not going to stop an infection on their own, because they have processes that aren't necessarily specific to fighting infection. They do all sorts of other things. They're kind of like a jack of all trades when it comes to the immune system. So artificially acquired immunity. This is what we think of when we talk about the use of vaccination, which really a vaccination is the creation of a biologic preparation containing an antigen that is specific to a disease and then introducing that to the person. There's vaccinations that are oral. There's vaccinations that are through the nose. There's vaccinations that we always think of that are intramuscular. And the idea is you're taking a antigen from a disease, introducing it to the body, and basically having the body create B cells for that. Because once you have B cells for that antigen, you have a subclass of those B cells that exist forever called memory B cells. And again, those are the guys that hang out elsewhere in the body, as I mentioned earlier. This type of immunity is not always permanent. Now, when we think about certain diseases like the diseases of childhood, like your measles, mumps, rubella, your chicken pox, etc., those diseases, you may only get your childhood vaccinations because as a immunocompetent adult, you would never actually become infected by those, right? So there's also that consideration as well, because remember, children and geriatric populations don't have a fully highly effective functioning immune system, and they're more prone to different types of infections. So a majority of the vaccines we think of are injected. And again, I basically summarized this slide already. So there are different types of vaccines, but again, their entire function is to stimulate that B cell response, have antibodies ready, because the antibodies sort of flag all of the bad stuff in the body so that our white blood cells and our T lymphocytes can target it. So our inactivated vaccinations are organisms that are killed or prevented from causing a disease. So if you have something like a virus, with a virus, the virus has essentially what's typically called a spike protein. The spike protein is how the virus gets through your cell walls. That spike protein will be removed typically in these inactivated forms, meaning that you can inject the virus into the body, but the virus is missing the only part of it that allows it to cause infection and get inside of your cells. You can also see certain bacterial strains will have changes to enzymes that they can secrete that make them essentially not function against our cells, or not even able to make those enzymes, because a lot of bacteria, they either chemically or, well, really, it is chemical for the most part. Chemically, they attack our cell membranes to get into our cells. And so if we can prevent them from doing that, again, same idea, it can't be infectious. Attenuated. Now, these are what you typically think of as something like a live organism. In this case, this is a whole bacteria, a whole virus, but it's still modified typically to the point that it is not capable of reproducing in the body. So even if it does cause a minor infection, that infection is going to be very, very, very controlled, because the virus or the bacteria can't divide for some modified reason. We've essentially found that certain infections are better treated with this. It provides a better immunity, and it provides a more long-term immunity. Because if you're introducing a whole organism to the body, you're actually likely producing more antibody types. So rather than just making an antibody for just one protein, one part of that specific organism, you've introduced the whole organism. Now we're making a ton of different antigens, which in reality, that's better for us in the long run, because that can give us attenuation. Attenuation can give us a more comprehensive immune system for more things, especially related diseases. There's also vaccines for toxins. Things like botulism, right? Botulism is caused by a toxin. I do not believe that there's actually a vaccine for that, but off the top of my head, that's one of the most commonly understood toxins of the body. And we can actually make vaccines for certain toxins. And then there's biosynthetic substances. Basically, we've, in some cases, completely removed the need for having inactivated or attenuated viruses and bacteria, and have been able to essentially create an immune response that is appropriate for those antigens without even having to introduce an organism or part of an organism at all. We can also have artificially acquired passive immunity. This is a rare case where antibodies from another person are injected into your body. Key examples for this, things like tetanus. Tetanus is treated with this. Snake bites are treated with this. When you think about things like antivenom, that is where this comes from. Rogam is another example of that. If you've ever been pregnant or know and are close to somebody that's been pregnant, there is a blood marker that basically gives you the positive or negative aspect of your blood. So you could be A positive or A negative. That's the Rho factor, the RH. And it is very possible for a mother to be Rh positive or negative, and the baby would be the opposite. So if the mother was Rh negative and the baby was Rh positive, that's actually a major problem, because the mother's body, which is giving antibodies and white blood cells to the developing fetus, that can lead to the creation of antibodies to that Rho protein. So you don't typically see on the first pregnancy a problem with that. But the moment a second pregnancy happens and there's an Rh positive fetus, you would actually essentially have the body attack and destroy the fetus's red blood cells, which essentially leads to death. So, moving on to our more drug-specific talking points. With immunosuppressive therapy, this is something we use when the body's immune system is out of control. It's reacting to something that we don't want it to react to. One of the most common ways that we think about that is transplants and autoimmune diseases. These responses are, for us, we know that they're not appropriate, but the body says, I need to attack and damage this thing because it's bad. So with transplantation, this is a big one. You essentially have to destroy off your own body, because T cells and white cells will kill the transplanted organs, because nobody has a perfect match of antigens. And in fact, when they're doing transplanted organs, they are checking so many different factors, which is why it can be so hard for people to find matches. Acute rejection is typically one of the more deadly complications of this, because, you know, depending on the organ and depending on the overall health of the person, they may not be able to live without that organ that was just put in. And sometimes you wait years for an organ. And if your body is going to destroy your organ starting within 3 months of it being put in, there's no chance to get another organ. You can also get acute rejection that will randomly kind of spike up at later points as well. The main way we try to prevent this, though, is just shutting down our immune system in various ways. So corticosteroids, typically one of the more first-line drugs for this type of stuff. They suppress production of white blood cells and which will inhibit your immune response. Now, corticosteroids used to be given out like candy, but we have realized that they have lots of other effects on the body that it makes them a lot less appropriate for long-term use. Another class is DMARDs, or disease-modifying antirheumatic drugs. These guys help reduce inflammatory disease processes. This is stuff like your methotrexate. DMARDs are highly effective. Cytotoxic drugs, we'll give these drugs to specifically try to kill immune cells. There's several different drugs. Methotrexate also does this as well. Methotrexate helps destroy T cells. There's also cyclophosphamide, which is very, very useful for autoimmune diseases. And then selective immunosuppressants, we have a couple of these. Some of them are more effective than others, and we use them to, in more specific cases, typically only for autoimmune disease. So selective immunosuppressants, one example of this is azathioprine. It's a less selective than some of the others, but it can be highly effective because of that. It actually shuts down the metabolism of a substance called purines, and purines are key for DNA synthesis and cell division. There's also calcineurin inhibitors. Those help stop T cell division from forming something called an immune complex, and inhibits the signaling factor calcineurin. That's typically used for transplant, to prevent transplant rejection. There's monoclonal antibodies, which we actually grow in a lab in mice. And then there's polyclonal antibodies, which we can direct against human T cells. And both of these areas are actually very fascinating and newer. And we're actually seeing lots of really good results and lots of drugs that are currently undergoing later stage trials that seem to have some fair promise, especially in terms of being more selective, because again, it's an antibody. We tell it exactly what to target. If we can make it target one very specific thing, we can reduce unintended side effects. Which brings us to our next key point. Immunosuppression in general, no matter what class of drug you're using, has an intended response of slowing down your immune system and reducing inflammation. This means that things like transplant rejection and autoimmune diseases have a reduced impact on you. The problem becomes balancing our immune function to be able to have a normal life and balancing symptoms and damage to transplanted organs. So, the increased risk of cancer development is a major concern with some of these. And for a lot of the other drugs, it's based on their mechanism of action. So a lot of them can be highly toxic to the liver. And we can also see issues with electrolyte balances. Some of them also have serious allergic response risks as well. Important things to consider: pregnancy and lactation. Contraindication for pregnancy, typically. Individuals on these drugs are basically required to use at least 2 forms of contraceptive during the use. Breastfeeding is also contraindicated. There's tons of evidence available related to birth defects and developmental disorders. So, moving on to our neurological medications and treatments. we're going to start talking about seizures. So there's different types of seizures, but the main idea of what a seizure is inappropriate excess electrical activity of the brain. Typically, people think of epilepsy when you think of seizures. A lot of individuals with epilepsy are responsive to light. So what happens is you get light stimulus through your eye that increases the transmission of signaling, because essentially the brighter a light is, or the greater the change in light in a short period of time, that induces faster transmission. Okay? And so that can kind of trigger a runaway signaling cascade in the brain. Seizure disorders are actually not that uncommon. About 2% of people suffer from them, and over half of those actually never have another seizure after that. Okay? So it can be rather vexing to just have one seizure, but it's relatively likely you never will have another one again. So in general, when you're trying to diagnose seizure, you use an EEG, an electroencephalogram, and you're measuring brain activity. This just shows examples of absent seizures versus tonic-clonic seizures. So types of seizures. One of the most dangerous type is status epilepticus. That's life-threatening, and it's a continuous seizure. You essentially have seizure after seizure after seizure after seizure. There's no refractory period in the brain, and it essentially burns out the neurons and you die. Now, generalized seizures, these affect most of the brain, and these are your standard, what people think of when people kind of shake or can go absent, meaning they kind of just stop there and just stare ahead. And then there's partial seizures, which can be focal or local, and those are a little bit different in the sense that they tend to only affect small parts of the brain. So you might see somebody, it might present like a stroke almost, right? And it can also present in other really weird ways. So treatment, prevention, and control. Typically with anti-seizure drugs, the idea is you want to shut down excess nerve conduction. Now, that typically does have side effects for that. You're basically giving people sedative type drugs. Now, when somebody's actually having a seizure, it's important to ensure they're in a safe environment. Make sure they're on the floor. It's typically suggested to try to put a cushion under their head, especially if they are shaking their head to where it's going to hit the ground. You want to put them in the recovery position. Loosen clothing, especially anything around the neck, like in this picture here, the guy's wearing a tie. You want to loosen that. Remove sharp objects from the area. Do not put anything in their mouth, and do not attempt to restrain them, because that can just hurt you and that can hurt them. Their body is not, if they're producing like myoclonic type jerking motions, their body doesn't actually necessarily have muscle inhibition. You can also help contribute to things like joint dislocation and fractures because of that if you try to restrain them. There are some stereotypical injuries that occur when people have seizures, which includes things like posterior shoulder dislocations, which are exceptionally rare outside of somebody having a seizure or electrical shock. But in general, keep the environment safe, ensure that they're on the ground, and just step back and go from there. If they've never had a seizure before, call 911. If they have a known seizure disorder, check for like a medical alert bracelet. So look on their wrists, look on their neck, or check their wallet. They may have something like that there. And nowadays phones have things that are like a medical ID card that might include information on if they have a condition like this. If they know they have a condition like this, generally in the medical setting, you're still going to dial 911. But if it's somebody that you know, I would tend to follow the directions on their medical alert documentation. And typically, if the seizure ends up lasting longer than a few minutes, then you will call 911 regardless of what it says. So, general things to think about. Level of consciousness. Again, these seizure medications can reduce level of consciousness because we're slowing down brain activity, right? It's exceptionally important to ensure the patient is not just going unconscious, unresponsive, and can't have a high quality of life, because that could be a major problem with these drugs. So first-line drugs. First-line drugs are our drugs that we want to use first. That's because they typically, for the average person, have a greater level of effect with slightly reduced levels of side effects. So these are things like your valproic acid, which increase the availability of GABA. GABA is your primary central nervous system inhibitor neurotransmitter. So that's going to increase the amount of GABA available, and that inhibits the central nervous system. Carbamazepine decreases impulse transmission by basically hyperpolarizing the neuron, and it does that through sodium channels. So remember, you need sodium and potassium to balance on inside and outside of the cell. And if you can prevent sodium, in this case, from moving in order to reduce changes in cell cross-membrane differentials, you will reduce the signaling. And then we have drugs like phenytoin, or commonly known as Dilaudid. This changes ion transport as well. It affects sodium, but it also affects other ions, which has the same type of things to think about. The intended response here: control the seizure, decrease electrical impulses. So side effects, very common: nausea, vomiting. You're going to see that almost every medication, and that's just, as I talked about in the first week, that's just a natural side effect of the way we study drugs. You also see common other side effects like confusion. There can be allergic reactions as well to just about any drug. Some drugs like ethosuximide, they can cause neutropenia and pancytopenia, which is essentially leads to aplastic anemia. You get a reduction in just about every type of blood cell that exists. So second-line drugs, these are alternatives and are less appropriate for the average person because they often can cause things like physical dependence, which is essentially addiction, right? So these are things like phenobarbital, primidone, gabapentin, clonazepam. You will also hear these drugs used in other chapters, like when we talk about the psychiatry chapter. Okay, so again, some psychiatric diseases have a pathophysiology that is thought to be related to too much neurotransmission. So things like clonazepam and phenobarbital will help slow down signaling. Gabapentin also is another GABA-related drug. You typically see it used in like neuropathies and stuff like that, but it can be used in this to help reduce electrical activity, because again, that's still what it's ultimately doing in the end. Moving on, Alzheimer's and Parkinson's chapter. So Alzheimer's is our most common form of dementia. There are multiple different forms of dementia. Parkinson's, on the other hand, is a neurodegenerative disease that primarily affects the motor neurons of the body, but it also has other issues. And Parkinson's and Alzheimer's are both theorized to be rooted in dysfunctions related to dopamine and acetylcholine. So Alzheimer's disease, this is progressive, it's incurable. Neurons die. That's essentially what it causes. And you start to lose intellectual ability, higher functioning, and then eventually the person stops being a person, right? We also can get neurofibrillary tangles, and clumps of plaques that form in the brain as well. So this is a comparison of a normal brain versus Alzheimer's brain, right? You start to see that the ventricles enlarge in Alzheimer's, the sulci get bigger, the sulci get bigger, the gyri have a bigger space between them because of that. Neurons have died. So Alzheimer's disease, we're commonly going to treat those with cholinesterase or acetylcholinesterase inhibitors. Remember, acetylcholinesterase is the enzyme that breaks down acetylcholine in the synaptic cleft. Cholinesterase drugs are drugs that will enhance the function or availability of acetylcholine. So you see the trend here. The idea is to increase the activity of acetylcholine. And again, we do that by having more acetylcholine or reducing the degradation of acetylcholine. One of the commonly used things is memantine as well, and it helps prevent overstimulation of brain receptors. So with this, because we can't cure it, we just want to slow its effect and keep quality of life high for a long period of time. Now, remember, acetylcholine is used for all, well, not all, but a majority of our nerve transmission. Muscle, highly useful. Visceral transmissions from our sympathetic and parasympathetic nervous system. Acetylcholine plays a role in that as well. So you might see things like abnormal heart rhythms, GI upset, GI bleeding, problems urinating. It can even cause seizures, and you can see things like trouble breathing, hallucinations, excess sweating, bradycardia, all kinds of things, even muscle weakness. If an individual has kind of any of the things that we're looking at here, GI bleeding, liver, kidney, heart disease, you got to be very careful with the drug. Donepezil can also help increase the risk of fractures. So that's why it says older, frail females should not take above a certain dosage of it. It's going to increase the risk of fracture, and the geriatric female population that's post-menopause is already at a very high risk of fracture, and you would be worried of things like vertebral fractures and hip fractures, as those two things can remove a large amount of quality of life for somebody very easily. Parkinson's disease. So Parkinson's disease is related to an area of the brain called the substantia nigra. This is a basal ganglia of the brain. It's within the thalamus, and this basal ganglia is one of the primary places where the neurotransmitter dopamine is made. The substantia nigra is named that because it is, as you can see in this slide, it's a very dark region of the brain. In fact, if you look up pictures of the gross anatomical specimens of this area, you will see that the substantia nigra nucleus is very dark compared to the stuff around it. With Parkinson's, you get that stereotypical pill rolling tremor. People get rigid, they get stiff, they have poor posture, there's balance issues. You'll also see gait dysfunction. They start their steps really slow, and then they speed up, and it starts to look more normal, right? And they can also have the reverse, where it takes them a couple extra steps to actually stop walking. The drugs we use in this are things like carbidopa, levodopa. We want to increase the effect of dopamine. We also need, in this case, to use things like acetylcholinesterase agonists to help prevent rigidity. So we would be looking for anticholinergics. Side effects: hypotension is a big one, dizziness, nausea. Dopamine and some of these drugs can be pretty gnarly for the person's psychiatric health. They can also cause rhabdomyolysis, which is excessive breakdown of muscle tissue, which is actually toxic to the kidney, and it essentially leads to kidney failure. So pregnancy and breastfeeding, this is one of those things that you don't get to test We don't actively intentionally test drugs on pregnant individuals or those that are breastfeeding. Now, we will gather information when that information becomes available. So if you have somebody in a drug trial that's pregnant, you collect all the information you can, you find out they're pregnant, they're out of the trial now, right? You've got information and you continue to follow up with them from that point, but you don't intentionally test it. And individuals that are pregnant tend to not develop Parkinson's to begin with, because Parkinson's, again, people over 50, 55 is when you start to worry about that. Insomnia. So this is something that we hear about a lot. It's basically the inability to fall asleep or remain asleep. It eventually leads to disruption of your everyday life. You have difficulty falling asleep. You'll wake often during the night, early mornings, don't feel rested after sleep, and it leads to sleep deprivation, which is very bad for the nervous system. Drugs used for this are basically GABA stimulants. We want to use things like benzodiazepines. Those are receptor agonists, so they turn on your GABA receptors. Barbiturates. These are across the board CNS depressors. And there's also antihistamines. So if anyone's ever taken, one extra Benadryl by accident, some individuals also, I know personally, I'm highly affected by Benadryl. I can't take Benadryl because if I even take one, even though as an adult, you're able to take 2 or 3, I even take one, I'm tired for 6-7 hours, and falling asleep while doing work type of tired. So in some individuals, antihistamines can have these sedating effects and makes it highly effective. You can also see skeletal muscle relaxants. In general, those guys depress the CNS, but as we'll talk about later, they're actually a very poorly understood drug class. We don't really know a lot about why they work, how they work. So it's something to think about. Again, intended response, get the person to sleep, refresh their immune system or their nervous system, and improve not just the length of time they're asleep, but the amount of times that they wake up during their sleep. Now, major side effects to this, again, just like every drug where we depress the immune system, you can have issues with memory, drowsiness, lethargy. You're also going to have your very standard side effects we see on every drug: diarrhea, nausea, vomiting. Next, eyes. Eyes are often thought of as the window to the immune system. Anyone that studies neuroscience does a lot of work on the eye because it's one of the only organs of the nervous system we can assess externally without actually having to touch it, right? We can watch things happen in the eye, and it tells us a lot about neurosignaling. And the eye actually is very interesting for essentially getting an insight to the nervous system, right? Like, one of the first signs and symptoms of things like increased intracranial pressure is papilledema. So when you're looking at the eye, you see papilledema present, and you know that there's potentially increased pressure in the skull, right? Which can be a very important emergency care type of situation. Here's a quick review of the anatomy and external eye features. Key things to think about with the eye is the lens of the eye, the cornea of the eye, and then changes to the pressure of the humors on the inside. So remember, you have your vitreous humor and your aqueous humor. Aqueous humor being in that anterior portion of the eye, and your vitreous humor being in the posterior portion of the eye. So first thing to talk about is glaucoma. Typically, glaucoma only affects one eye, but if one eye has it, there's a high risk that your other eye will eventually get it. Okay, so it can also affect both eyes at the same time. Doesn't really matter all that much, but there is increased intraocular pressure. There's different types of glaucoma, but the most common is primary open-angle glaucoma. It's actually painless, and the only initial symptom is a loss of peripheral vision. You can also see glaucoma being caused by the blocking of the canal of Schlemm, which, if we come back here, your canal of Schlemm is through here. That's where your tears drain and it builds up pressure. Where was I? Okay, so typically drugs for this are going to be topical, like most eye drugs actually are. You use them in the form of things like drops, right? So you do want to do your best to clean the eye when using the drug. Typically, people can wear contact lenses. They just have to take them out for a short period of time while administering their medication. Key things for glaucoma: you want to ensure that you're applying general pressure to help prevent the drug from leaving the surface of the eye too quickly, right? So you want to block the punctum, which is the term for the little hole that leads into the canal, the canaliculi and the canal Schlemm, etc., where it drains through. For pediatric patients, again, it's typically blockage of these drainage that cause it. Some of the drugs aren't tested in children at all. A lot of these drugs, though, do need to be avoided during pregnancy and with lactation. And older adults often have physical limitations related to shoulder injuries. Typically, anybody over the age of 55 is at a high risk for either having or developing shoulder rotator cuff tears, which can actually prevent the person from lifting their arm up to put an eye drop in. So there are adaptive devices, and this is something that occupational therapy is highly effective at for patients. So one type of drug we use is a prostaglandin agonist. Prostaglandin is a blood vessel dilator, so it's going to increase blood flow. Prostaglandin is a key signaling factor in inflammation, which is why it increases blood flow. With increased blood flow, you get the ability to collect more of the aqueous humor. Therefore, we reduce pressure in the eye. A lot of people with this, though, can have eye itching, which is one of the things I've seen most common with people that have this. But more adverse effects you can see are things like hypotension, because, again, dilate the blood vessels. We're making the vessel bigger, and that reduces blood pressure. Again, inspect the eye, teach a patient how to apply them properly. Beta-adrenergic blocking agents. So we'll talk about these kind of things at different times. The idea here is to cause the fluid in the eye to be absorbed better. And you can also see certain drugs producing less aqueous humor as well. It's important for these because beta-adrenergic blockers can be used in people with heart failure and diseases like COPD, which, again, we'll talk about that later on. But these can affect the treatment of those conditions as well, because you're going to block your beta-adrenergic receptors, which have function in both heart rate and breathing. Specifically in breathing, you'll see a drop in heart rate, and in the cardiovascular system, you see the drop in heart rate, and with the respiratory system, you get a drop in pulse oxygenation because you're slowing down breathing rate. Alpha adrenergics, again, we'll talk about these more in depth later on, but these primarily produce less aqueous humor as a result, and they can also dilate the pupil to help improve fluid flow through it. Therefore, we reduce intraocular pressure. These are often used in short-term therapies to help get the initial pressure a little bit under control, especially if it is way too high and threatening to start actually having changes in vision. With this, you'll get blurred vision, dilated pupils. You can see itchiness, redness, and tearing. So you likely will see an increased amount of fluid leaving the eye. And again, that's kind of the goal here, right? So whether you call that a side effect or a intended effect, it's kind of up to how bad it is, I guess. Alpha adrenergics also have an impact on blood pressure and heart rate. So you could see decreased blood pressure, slowing heart rates. So vital signs are important to monitor in these patients. Cholinergic drugs, again, these are acetylcholine agonists. We've talked about these already. You can get miosis, tearing, a burning sensation of the eye, and any eye drop can cause a burning sensation, right? It can cause blurred vision, it can cause redness, etc. Those types of things are good to think about. Because of the role of acetylcholine in signaling of the cardiovascular system, GI system, the urinary system, you can see issues with all of those things because of it, right? Remember, a drug has a mechanism of action. Side effects are functionally that mechanism of action in an unintended way. Okay, so the last thing we're going to talk about is carbonic anhydrase inhibitors. The CAIs are they're one of the only drugs we can actually take orally in this situation. Some people react better orally, but one of the more adverse effects we have with this is acidosis. Carbonic anhydrase is a key enzyme used in helping regulate the pH level in the body and electrolyte imbalances. So you need to be very careful with that. They also typically say individuals with a sulfonamide drug class allergy should be careful with these drugs. We'll talk about sulfonamides in a later video. Also, the carbonic anhydrase inhibitor, the oral medication form, is typically where we worry about the acidosis. The eye drops, it's not all that common. And again, this is another drug. You don't use it in children, you don't use it while pregnant, and you don't use it while breastfeeding. So that is everything for our overview of our immune drugs and our nervous system drugs.